Hello, everyone. I'm Prutha Pathak, PGY1 at NAMC in Florence, Alabama. Today, I'm going to talk about cocaine-induced ascending aortic thrombus. So aortic thrombi usually are associated in already pre-existingly damaged vessels like those where there is existing severe atherosclerosis, where patients have had aortic aneurysms or patients have had dissections in the past. And common locations in the literature have been in the descending thoracic aorta as well as the aortic arch. Very rarely in literature is an ascending aortic thrombus in a anatomically normal aorta reported, which is why our case is interesting because our patient had an ascending aortic thrombus in a non-aneurysmal, non-dissected aorta. And I'm sure all of you know the mechanism by which cocaine causes both vasoconstriction and a hypercoagulable state. So it's complex, but the prothrombotic effects are because of endothelial damage, because of increased fibrinogen release, the increased interaction between von Willebrand factor and platelets, which increases platelet aggregation. And then, of course, the adrenergically mediated vasoconstriction that we all know. This is both of arteries and veins. And there is also reported, these are hypotheses, but there is also reports that cocaine reduces tissue plasminogen activator activity, increases tissue plasminogen activator inhibitor activity, and factor 12 deficiency. As you know, all of this increases hypercoagulability. So our case, this was a 55-year-old African-American gentleman. He was admitted to the hospital with chest pain, with burning quality chest pain radiating to the left shoulder of 2-hour duration. He has existing hypertension and diabetes, and he is a regular cocaine and amphetamine user. When he presented, he had hypotensive emergency with a BP of 180, 207 mm Hg. He was saturating well at 97% on room air, and his pulse and respirations were 85 and 19 respectively, and he was afebrile. On physical exam, heart sounds were normal. There were no murmurs, rubs, or gallops appreciated, and respiratory exam was normal with no wheeze, rhonchi, or crackles. There was no peripheral edema. Labs determined a normal WBC count of 7,000, hemoglobin of 14.6, creatinine of 1. Troponins were elevated at 93, but they downtrended on subsequent labs. His proBNP was 38, and there was an elevated D-dimer at 1.71. The patient also had positive cocaine on UDS. EKG demonstrated normal sinus rhythm with non-specific STT wave changes, and the echo was normal with a 65% ejection fraction with no regional wall abnormalities. As a subsequent test to his elevated D-dimer, a PE was suspected and a CTA was performed. And it was incidentally on the CTA that a relatively large 2.5 by 1.2 centimeter thrombus was found adherent to the ascending aorta, and the aorta was normal without any aneurysm calcification or dissection. So because the patient had a thrombus, which was significantly large in size, the patient was initiated on a heparin drip, and unfortunately, the patient was lost to follow-up. But what was very interesting is that 2 months later, the patient actually presented to the hospital again. This time, he had a femoral artery, groin pain, and there were embolic phenomena in the femoral artery. And despite the patient not being anticoagulated, the thrombus continued to be the same in size. Neither did it increase in size. It was shooting emboli, downward in the circulation, but it stayed stable at exactly the same location. And of course, you can see the thrombus here in the ascending aorta on the CT scan. So the take-home points is that we already know that cocaine raises thrombogenicity right from veins, small vessels, and even to the largest vessels as large as the ascending aorta. Ascending aortic thrombi can be treated medically. So if the thrombi are large, we can consult CVTS, which we did, and they may go for endovascular repair or surgery. But our patient was treated medically and not even complete compliance to anticoagulation, but still the patient was clinically stable. And patients can also present with thrombi, and not every chest pain due to cocaine is coronary vasospasm. So physicians should keep suspicion for thrombi high in regular cocaine users. Thank you.
Thank you, Prutha, for the amazing presentation. Good question. In this case would be, how would you know that was cocaine that was induced the thrombus versus other causes?
Right. So we did think about that. So the etiology, the temporality was that the patient had used cocaine the morning of used cocaine the morning of the chest pain, and then also the patient had a UDS positive. Of course, we can't say for sure because the patient also has other risk factors, like he's hypertensive. But considering the temporality of the use, and then also some case reports being published in existing clinical literature, we believe it was cocaine-induced.